Hello, my dear friends. Welcome to today's session and hope all of you are doing well. I'm Dr. Anuradha Dhawan, and in today's session, it is targeted towards a recall session for your 4th June exam, which was conducted. And we are going to discuss the ophthalmology questions which were there in the exam. Before we begin this session, I would like to just highlight that since it is a recall-based session, so the question statement and the choices may not be exactly the same which was there in the exam. And I invite you to give your input in the comment sections of the video to add on to the questions or the choices, because some of the questions are still incomplete. So because that will be helpful for the people who will be appearing in the future exams. So you are most welcome to give your input in the comment sections. And another thing before I start, I would like to share is that through my interaction with you people, it was known that most of the topics were in ophthalmology, especially, were quite familiar. We got a good number of questions in this exam in ophthalmology. And they were mostly from the familiar topics which we had discussed in our classes, in our revision sessions, and in our expected question sessions, mock test, etc. So I'm hopeful that that must have helped you through the exam, and I wish you all the best for your result. And let's begin the session and let's go through these questions. So starting here, let's go through the first question. So first question, one of the questions which was there in the exam, I think the only image or just one of the few questions which were image-based this time was this question, in which you were given a slit lamp image of the interior segment and they asked you to identify the given lesion. So I think this image we have revised many a times, and it was a very straightforward question. They had given you this image and you had to mark the right answer. So dear friends, this was the image of a dendritic ulcer. Okay, so this is the image of dendritic ulcer. You are here, you can see the typical dendritic lesion, which we know is a characteristic feature of viral keratitis. So this was a pretty straightforward question. The right answer to this question is viral keratitis. The image shown in here is your dendritic ulcer. Rest of the choices, they are absolutely, you can mark them out. Right answer to this question was viral keratitis. Okay. Moving on to the second question. So this question was a relatively newly put question. Coip nodules are seen in. The choices given were most likely iris, cornea, sclera, and conjunctiva. Now, coip nodules, friends, they are a type of the iris nodules. Let me take you through the iris nodules. Iris nodules, as you know, they are feature of the uveitis, specifically the granulomatous type of the uveitis. There are two types of the nodules which we can see. One are known as Busacca nodules. The second one are known as coip nodules. So Busacca nodules, they are found on the body of the iris or the iris stroma. So B for the body of the iris or base of the iris and P for Busacca. Coip nodules, as you are seeing here, they are seen at the pupillary margin. So this was asked in the exam. They didn't give the image, but they asked you that where the coip nodules are found. So coip nodules are your iris nodule, friends. They are feature of granulomatous uveitis. Okay. Going to the next question. The next question was again a question which has been frequently studied in the classes. A child from the poor socioeconomic background presents with white foamy spots in both the eyes. So these were the key words, white foamy spots in both the eyes. What could be the reason? So what they here were asking, what are these white foamy spots they were asking? I'm sure you were able to recognize it. They were talking about the bited spots. Okay. We know bited spots, they look like frothy or foamy lesions. They're typically whitish in color, seen on bulbar conjunctiva, mostly the temporal side. Okay. Bited spots, they are feature of one of the signs of vitamin A deficiency. So we know we have studied a spectrum of the vitamin A deficiency signs and symptoms in eye, which are known as xerophthalmia. So you had to identify that the question is asking about the bited spot, and then the choices given were most likely, which was like told to me, were the conjunctival xerosis, vitamin D deficiency, B and C. So they didn't directly ask for the vitamin A deficiency, but you had to identify that since xerosis is also a feature of vitamin A deficiency, and the stage of conjunctival xerosis comes before the appearance of bited spots. So it means if there are bited spots, there is already conjunctival xerosis. So the reason is vitamin A deficiency symptoms, and the choice which had to be marked over here was the conjunctival xerosis. So again, a good question and often asked question in a different way. Moving on to the next question. The next question was again a good case scenario. Let's see what was the question. A patient presents with a symptom of floaters, flashes, and then a curtain-like shadow coming in front of the eye. So in the given case situation, they have given typical symptoms of what, my dear friends? Retinal detachment, rhegmatogenous retinal detachment. So that's what they were asking, what could be the probable diagnosis? So we have discussed that retinal detachment, the rhegmatogenous type, occurs because of the retinal break. Now, when these changes are happening because of the vitreous syneresis, the initial symptoms are, we know, floaters, flashes of light, which are also known as photopsia. And then once the detachment occurs, you see the retina, which is detached over here, you can see the whole retina kind of becomes ballooned up. The retina detaches and it kind of becomes ballooned up. Convex configuration of the detachment, and it covers the field of the vision like a curtain is falling on the field of the vision. So these key words in the case scenario were very, very typical: floaters, flashes, and then a curtain-like shadow. So the right answer to this question out of the choices given was very direct, that is retinal detachment. Okay, so retinal detachment, rhegmatogenous retinal detachment was the thing which examiner was talking about. Moving on to another question. Now, this was relatively a new question for FMGE exam, I would say, but a good question. Let's go through the most likely. The question statement was like this: a child is being considered for intraocular lens implantation. That is, they're talking most likely about the congenital cataract. And now you are considering the child for intraocular lens implantation. What should be kept in mind in such cases while choosing IOL power? Okay. The choices which were given were hyperopic shift, myopic shift, growth of the lens capsule with the age, length of the lens capsule. Now we know that when we do intraocular lens implantation for adults, we use a formula to calculate the IOL power. Now, what is different in a child? That was being asked. Now, if you see, a child is born with a small eyeball, hypermetropic. Okay. As the child grows, the eyeball increases in size, the axial length increases in size. Now, the hypermetropic error, which is normal physiological in children, now it undergoes a myopic shift because the axial length is increasing. This is a normal phenomena occurring when the eyeball grows in children. So when you are choosing the IOL power, in a child, one has to take care of this myopic shift because this is happening. The child is in the growing phase. Because of the myopic shift, we do under correction of the intraocular lens power. Okay, so if you are putting an IOL in a child who is less than 2 years of the age, you will give 80% of the power which has been calculated. Okay, if you are putting it in a child who is between 2 to 8 years of the age, you'll be using 90% of the power which is given by the formula. Okay? After the age of 8 years, because the growth of the eyeball is complete, you can give, just like adults, 100% of the IOL power. Okay. So what is the factor or what is the parameter which you will take into consideration when you are using IOL for a child? That is myopic shift. You have to compensate for that myopic shift, which we do by doing the undercorrection, as I told you. Okay. So this was the question based upon that, the IOL parameter in children. Then another question was a very typical question which has been coming as an image-based question, but this time they did not give the image, but they gave you the characteristic history. So what was the question? It was a 3-year-old boy presents with itching and red eyes, which is more in summer. There is also ropy discharge from the eyes. So you can see in the case history, they have given you the typical signs and symptoms. What are the symptoms? Itchy eyes, red eyes, more in summer season. Okay. Then see the age group, a young boy. In the signs, there is also a ropy discharge. Now, all these features, they are very, very typical of, as you know, spring catarrh or vernal keratoconjunctivitis. Okay. More in summer, ropy discharge, itching, all going in favor of vernal keratoconjunctivitis. If you see the other choices is GPC, that is giant papillary conjunctivitis. We know that is usually due to secondary to the contact lenses. It has no relation to the season. Keratoconjunctivitis sicca is dry eyes. So dry eyes can have redness, itchiness, but ropy discharge or relation with the summer season will not be seen. Doesn't look like features of corneal ulcer. So this case scenario was of spring catarrh, or in other words, vernal keratoconjunctivitis or VKC. So again, this case scenario has been many a times asked. This time it was without an image, but typical features were given, which was easy to identify the right answer. Moving on to the next question. Now, this was again a relatively new question, I would say, based upon the case scenario. Let's see what was the question. A patient presents with bilateral ptosis, which is variable during the day and reduces on putting the ice packs. Now, again, typical history and the characteristic features of the condition was given. You had to make the most likely diagnosis. Now, patient having bilateral ptosis. So first of all, one has to see what are the conditions which can cause bilateral ptosis out of the choices. Horner syndrome, the ptosis is not usually bilateral. Third nerve palsy, again, the bilateral, very, very rare. So between B and C, that is myasthenia gravis, and another choice given was chronic progressive external ophthalmoplegia, in which there are multiple cranial nerve palsies. These are the two which can have the bilateral ptosis among these two. But when there is written in the history that the ptosis is variable, there is diurnal variation. Now this sign or symptom, when we see, it goes in favor of myasthenia gravis. And another characteristic feature which clinches the diagnosis is that ptosis reduces on putting the ice packs. So actually there are two tests which can be easily done to confirm the diagnosis of the myasthenia gravis. One is by putting the ice packs on the eyes. Now, in myasthenia gravis, we know there is deficiency of acetylcholine on the neuromuscular junction. So when you put the ice packs, the availability of the acetylcholine increases. Okay, so that improves. You see this figure, A is the ptosis in the eye before putting the ice pack, and then B is after putting the ice packs. So ptosis improves. Another test which is done in the cases of myasthenia gravis is known as tensilon test or neostigmine test, that when you give neostigmine, the ptosis improves because acetylcholine availability improves. So these two features, that the variable ptosis, the ptosis which is more in the, as the day passes, there is diurnal variation due to muscle fatigue, and the one which reduces by putting the ice packs, that clinch the diagnosis of myasthenia gravis. Okay. variable ptosis, bilateral ptosis, the ptosis which improves on putting the ice packs, goes in favor of myasthenia gravis. So that was the right answer in this case. Now, regarding this question, I'm a little doubtful whether it was directly the image identification or was there a history of orbital trauma. But I think the question was related to that this image was given and you had to identify that what fracture it is. So this image, again, a very familiar image we have discussed in our classes. So this here you notice that there is a fracture of the floor of the orbit, okay? And you see the characteristic teardrop sign due to prolapse of the orbital contents into the maxillary sinus. So whatever way the question was, most likely you had to identify that it is the orbital floor fracture or the blowout fracture. Pretty straightforward question. If you can improve upon the choices or what was the case scenario, you can please add on the comments over here. But right answer to this question was the blowout fracture of the orbital floor, okay, which usually occurs following severe blunt trauma to the orbit. Moving on to another question, which was a case scenario, and from the very familiar topics of the antiglaucoma drugs, a very favorite for the examiner. Now, this time they asked that a 60-year-old man is being treated with antiglaucoma drug and his bronchial asthma got worsened. So they have given you side effect of one of the antiglaucoma drugs, that is worsening of the bronchial asthma. What could be the probable cause? The bronchial asthma worsening means that there is constriction of the airway passages. There is bronchoconstriction. Now, out of the choices given, brimonidine, brinzolamide, timolol, latanoprost, what do you think? Which drug can cause bronchoconstriction? That is your beta blockers. Beta blockers. So if you remember beta blocker, topical beta blockers, one of the commonly given drugs in glaucoma therapy, the local side effects of beta blockers are very, very minimal and mild. Dry eye or the punctate keratitis in some cases, but they have multiple systemic side effects due to which they are no longer the first line drugs. Beta blockers, they can cause bronchospasm, they can cause bradycardia, they can cause hypertension, sleep disorder, fatigue. So because of these systemic side effects, they are contraindicated in congestive heart failure, second or third degree heart block, bradycardia if patient has asthma, and COPD because they cause bronchospasm. Okay, so here in the given scenario, they had told us that patients' bronchial asthma got worsened. So which drug will be contraindicated or which can produce this kind of effect is your timolol, which is the beta blocker here. Okay, so right answer to this question was timolol. Then moving to another question from, again, a very familiar topic. The question was probably a case scenario that a lady presents with grade 2 pterygium. What would be the best treatment in this case? So grade 2 pterygium means it's covering the cornea. The pterygium, when it crosses the limbus and encroaches upon the cornea, but still not covering the pupillary area, that is your grade 2 pterygium. Okay. Now in pterygium, the concern which we have with the treatment is that if you just excise the pterygium, then there are high chances of recurrence. So it is always good to do the treatment to prevent the recurrence. And out of the choices given, the excision with conjunctival autograft is the best because that prevents the recurrence. If you see choice A, that is excision only, high chances of recurrence. Keratoplasty is not the treatment for pterygium. You excise the pterygium and then you apply a conjunctival autograft. So that will be the best treatment in this case. Besides the conjunctival autograft, you can also do amniotic membrane transplantation, but that is usually reserved for recurrent cases. best treatment as first line will be excision with the conjunctival autograft, which was the right answer to this question. Okay. Then moving to another question, again, a very good question, a very straightforward question, a case scenario in which they ask that the patient presents with hard painless nodule growing externally away from the lid margin. So they have described the lesion very beautifully. So first of all, you imagine that what lid nodules you want to consider when such kind of question is there. So we know there can be clasion, there can be stye, which is also known as external hordeolum, or there can be infected clasion, that is the clasion becomes infected, which is known as internal hordeolum. Now see, in this question, they have specifically told you that it is a painless nodule. So painless goes in favor of clasion, because if there is infection, for example, in stye or in internal hordeolum, it will be a painful nodule. Okay, then they have told you that it is growing away from the lid margin. We know the stye is in relation to the hair follicle. So if it is away from the lid margin, that it means it's related to meibomian gland. So again, it goes in favor of clasion. If you remember, we have seen these images many a time. Here you notice in the upper image, a nodule, which is away from the lid margin. Okay, so it appears more prominently externally. Clasion will always appear more prominent externally than at the internal surface. So there will be an external swelling, but it will be painless and it will be from away from the lid margin. If you look at the stye is always painful and it is in relation to the hair follicle. So here, what they had asked in the question, painless nodule growing away from the lid margin. So I hope the choice was very, very clear in terms of clasion. So clasion is the right answer here, not the external or internal hordeolum, of course, not the entropyon. I don't know what was exactly the fourth choice, but the clasion is the clear-cut answer to this question. Then friends, moving on to the next question. This was a relatively new question in terms of the treatment. The patient has distress on reading. So nicely put question here, good case scenario. Patient has distress on reading. So means he's having some sort of difficulty or discomfort on reading. On examination, there is no problem of short-sightedness or long-sightedness, means there is no refractive error. So they have ruled out the refractive error, but Schirmer test reading is 5 millimeter. So we know Schirmer test is a test done for, we have learned it, dry eyes. Mostly, if the Schirmer test reading is less than 10 millimeter, that indicates a severe dry eye. So what is the treatment in this case? So I think the choice was very, very straightforward. Lubricants are the treatment for the dry eye. Steroids, antiallergic or glasses or any other thing is not required in this case. This is a case of dry eye, which is indicated by the Schirmer test, and to treat the dry eye, you will be giving the lubricant. So that was the right answer to be marked in this case, lubricants. Okay. Then a very, very favorite case scenario for the examiner, I would say the question on fungal ulcer has been coming almost in every exam now. This time it was not image-based, it was just the case scenario, but I think pretty straightforward. A patient suffered trauma with vegetative matter and then presented with ulcer and hypopyon and satellite lesion. So I think these keywords would have helped you to clinch the diagnosis very straightforward. Trauma with vegetative matter, then satellite lesions. So these two, they go in favor of fungal keratitis. So we can easily rule out bacteria, viral acanthamoeba, because once there is history of vegetative matter, once there is sign of satellite lesions, and hypopyon is also a very common feature of fungal ulcer, I think you must not have felt any difficulty in marking the right answer, which is the fungal keratitis. So sometimes the question can be image-based, sometimes the question can be based upon the case scenario, but very, very typical question for fungal keratitis. Then moving on to another favorite topic with the examiners. So this time they asked it, again, it's a case scenario. A child is brought by parents with white pupillary reflex. On examination, a cauliflower-like mass with calcification is seen growing from retina. So something like this case scenario was presented in the exam. What is the most likely diagnosis? Now see here again, if you look at all the key points which they have given in the question, white pupillary reflex means leukocoria. So whenever you see the question is talking about leukocoria, the differentials of leukocoria, in which the most important is retinoblastoma, should come into your mind. Okay. Then another clue was a mass with calcification. So tumor with calcification in a child, again, goes straight forward in the diagnosis of retinoblastoma. Okay, so if you remember, we have seen multiple times this image of white reflex in a child, and when the tumor is growing towards the vitreous cavity, that type of the growth pattern, the tumor appears like a cauliflower-like mass, as you can see in the image here. The calcification is highly suggestive of retinoblastoma. So I think the examiner had given very, very specific clues regarding the retinoblastoma. Cataract, yes, cataract can cause leukocoria, but there will not be any mass or tumor. Retinal detachment is not associated with calcification or cauliflower-like mass. Rhabdomyosarcoma is an orbital tumor. So these features in the case scenario were directly pointing towards the diagnosis of retinoblastoma, which was the correct answer in this question. Now then moving on to another case scenario. Now this question statement may be a little different from what was there, but what I could get the best was a case scenario like this was presented, that an elderly man who is one-eyed got punched in his only seeing eye. So there was a person who is one-eyed and now he has trauma, blunt trauma, punch in the only seeing eye. The patient presents with painful decrease in vision. What could be the cause? So the choices most likely were optic neuritis, retrobulbar neuritis, sympathetic ophthalmitis, conjunctival hemorrhage. Now here, if we go by the rule of ruling it out, conjunctival hemorrhage will not cause any decrease in vision. It is not related to decrease in vision. Sympathetic ophthalmitis will occur only if it is bilateral and it is associated with penetrating trauma. So this patient is one-eyed. So sympathetic ophthalmitis is ruled out. There is blunt trauma, not the penetrating trauma. Then retrobulbar neuritis, again, is most likely is not the reason here, because though they have not given the fundus finding, I'm not very sure whether the retrobulbar neuritis choice was there or not. But according to the students who recalled the question, they said optic neuritis was the choice. So most likely the right answer to this question will go in favor of optic neuritis. Optic neuritis, okay, painful decrease in vision after the trauma, traumatic optic neuropathy, or optic neuritis, okay? Then there was a question based upon the contact lens use related infection. Again, the question statement is, we are not 100% sure, but it was something like that the girl uses the contact lens shared by another person and then develops painful red eye. What could be the most likely cause? So among the choices which we could get was that there was definitely a choice for acanthamoeba keratitis. And maybe the others, they were candidiasis or conjunctivitis. So going here, painful red eye in association with contact lens use with poor hygiene, because if it is being used by another person, so that goes like a poor hygiene, high chance of developing infection related to contact lens. And according to the students, the pseudomonas was not in the choices. So there was no confusion between pseudomonas or acanthamoeba. So if the question was related like this, then acanthamoeba keratitis is the right answer to this question. It goes in favor of acanthamoeba keratitis. Okay? So if you have any additional input for this question, you can please write it down in the comments there. Then this was a new question based upon the refraction for as regard the FMG exam is concerned. Similar questions that have been coming in the NEET PG, but this time they asked in the FMG exam also. They gave you the retinoscopy findings. Okay, so they showed you an image of the retinoscopic findings. Most likely the question was like this, that the retinoscopy is done at a distance of 1 meter under atropine. What will be the glass prescription in this case? Now we know that when we do the retinoscopy, we neutralize the reflex in the two principal meridia, that is the 90 degree and the 180 degree. And accordingly here, the readings which were most likely +2 at the 90 degree meridia and +3 at the 180 degree meridia. Now friends, when we have the retinoscopy readings, how do we convert it into the spectacle prescription or the glass prescription? Okay, you have to subtract the working distance and the effect of the cycloplegia. So if the working distance was 1 meter and it was under atropine, you will subtract -1 for the working distance and -1 for the atropine. So the corrected retinoscopy now will be in the 90 degree or the vertical axis, it becomes 0. And at 180 degree or the horizontal axis, it remains +1 now. So it means you need a cylindrical, there is an astigmatism, there is a different refractive correction at 90 degree and 180 degree. Okay. Now you know that the cylinder acts at 90 degree to where it is placed. Okay. So if I want a cylinder to be acting at 180 degree, I have to place it at 90 degree. So here, the right answer to this question will be +1 diopter cylinder at 90 degree. Okay, because I need +1 acting at 180, I will be placing it at 90. Okay, so in the questions where you have to convert retinoscopy into glass prescription, you have to subtract the working distance, you have to subtract the cycloplegic effect, and then you have to see that whether it's only a spherical correction. In the given question, probably they asked only about the cylindrical correction. So in this prescription, the right answer will be +1 diopter cylindrical at 90 degree. We of course do not know what was the exact prescription, but this is how you solve these kind of questions. So this was relatively new for the FMG exam, but yes, every time there will be some addition to the questions which they ask. Then most likely the last question which was asked as far as ophthalmology was concerned, again was related to trauma. And I hope the question was like this, that a young boy suffered blunt trauma and develops monoocular diplopia. So question was related to development of monoocular diplopia after blunt trauma. What could be the reason? So this is an incomplete question, whatever we could get from the recall. If it was a monoocular diplopia after blunt trauma, then most likely it is due to iridodialysis. Okay, because severe blunt trauma can cause disinsertion of the iris from its root, as you are seeing here. Okay, so there becomes two pupils. The normal pupil becomes D-shaped, and then there is another gap here. So the person will have double image from one eye, that is monoocular diplopia. So question related to blunt trauma leading to monoocular diplopia, most likely if the choice was iridodialysis, that will be the right choice in this case. So with this, we have covered the most of the questions which were there in your June exam. And most of the questions, they were pretty straightforward, no confusion or controversial questions over there. You guys are most welcome to add if there is any further input to the recall session, because that will be helpful for the people who are, appearing in the upcoming exams. Because these are the high yield topics. And as you have seen, many of the questions, they were from the familiar topics. So high yield topics, they keep on getting repeated in the exams. So I'm sure that you had a good exam, and I wish you all the best for your result. May all of you pass with flying colors, and we'll be again meeting in another sessions, interacting with you. All the best till then from me and from the Miss team. Take care of yourself.